eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gill, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now stream our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube movies and shows. Macular degeneration, or AMD, is the leading cause of blindness in people over the age of 55. Identifying which patients with macular degeneration are at high risk for progression is crucial to preventing significant vision loss. With new diagnostic technology, physicians can now better monitor patients for progression from dry to wet macular degeneration, a transition that can happen quickly and lead to severe vision impairment if undetected and left untreated. Today, we're joined by Maryland retina specialist, Dr. Sidney Schechet. Dr. Schechet is an accomplished ophthalmologist and researcher with multiple publications in prominent journals like Retina and contributions to key textbooks such as Ryan's Retina. He has also been recognized for his innovative surgical techniques. Dr. Schechet, thank you for joining us today to discuss the latest in macular degeneration detection and care.
Thank you so much for having me. I'm super excited and ready to talk about it and have a good time tonight.
So I want to ask you something very simple, but sometimes very difficult to define. What is macular degeneration?
Macular degeneration is a very common disease in the retina clinic. It's one of the most common things that I see every day and treat. But outside of the retina clinic, it is a very uncommon disease that many people have never heard about. The macula is the center of the retina. The retina is the inner lining of the back of the eye. No one can see the retina. When you go to the eye doctor, you have to get your eyes dilated, the pupil dilated, so then the eye doctor can take a look inside and assess and look at the retina. The central sharp vision comes out of the macula, again, the center of the retina, and a lot of diseases could happen in the macula and in the retina. Macular degeneration is a disease where the macula degenerates, thus macular degeneration, and there's a lot of levels and types and subtypes, the most common being dry macular degeneration. Wet macular degeneration is the other large category, where about 10% of those with dry macular degeneration could unfortunately convert to wet macular degeneration, and that causes bleeding and swelling inside of the macula that disrupts the function and thus disrupts and affects the vision in a very significant way.
I want to make sure I'm pronouncing your right name right. Schechet, right? Is that
Yes, I didn't know
close?
if I don't want to interrupt. I mean, it doesn't matter to me.
Closely. You have it written on your shirt, but it's Schechet.
Yeah, there's a lot of E's and C's.
So, so would you say macular degeneration is a systemic vascular disease? There was a study done in the Survey of Ophthalmology that was written in 2010, and they talked about how macular degeneration is very common with people with chronic disease such as cardiovascular disease, hypertension, obesity, diabetes. So would you say it is a systemic vascular disease? And if you have problems with your heart, you also are at greater risk for macular degeneration and vice versa.
Yeah, I mean, I'll put it this way. The retina, when people say the eye is the window to the soul, they're really talking about the retina. No offense to the other parts of the eyeball. But the retina is vascular and has a lot of blood vessels, a lot of layers, a lot of types of tissue. It's predominantly, central nervous system tissue. It's brain tissue is what I tell the patients. And it is a mysterious, awe-inspiring part of the body that is honestly connected to many or every part of the body. Many systemic diseases are associated with it. Like you said, there's a significant role for genetics, a lot of environmental factors, inflammation. In fact, on the horizon, there will be ways to screen for, very, very devastating neurologic diseases like Alzheimer's and Parkinson's just by looking at the retina and doing imaging on the macula.
I mean, that's unbelievable that we're going to be at some point the first doctors that'll probably be able to tell if somebody's at risk for Alzheimer's disease. We use an instrument called OCT. Talk to me about OCT, what that does, and how that may be able to help us with early diagnosis of Alzheimer's.
I'll answer that with a anecdote that just popped up in my head. The other day, I had a patient who was a fancy schmancy radiologist, doctor that looks at X-rays and different imaging of the body. So they're into pictures, and in the retina, for the retina, there's a lot of types of imaging or pictures you can take of the retina and the macula specifically, that gives you all different sorts of information. OCT, optical coherence tomography, was a revolutionary, one of the greatest things for our field in ophthalmology and medicine, that literally does ultrasound, X-rays of the macula to such a fine, profound detail where you can see the layers of the macula. There's several layers, and on average, in different parts, there's different measurements, but on average, the macular thickness is 250 micrometers thick, basically thinner than a paper. And this OCT machine is within seconds can take a scan just by looking into the machine, and it can tell me not just how it looks, but they can give me all the details of all the layers, and there's a lot more to it. I don't want to nerd out too much. A more recent advancement to OCT is OCTA, OCT angiography. Angiography is a type of imaging where you're assessing the function of blood vessels. You can have CAT scan angiography, MRI angiography. So OCT angiography looks at the blood vessels, not just the layers of the macula itself, but also how the blood vessels look. Not in general, you can segment it to the capillaries and the different layers of it. So the OCTA is a burgeoning field where that imaging modality is starting to garner a lot of interest for assessing and screening for various systemic diseases, cardiovascular disease, high blood pressure, diabetes, cholesterol, risk of cardiovascular death, and like you said, Alzheimer's, Parkinson's, and other neurologic degenerative diseases.
So we're talking about macular degeneration a lot tonight, and talk to me about the epidemiology of it. How many people have it? How common is it? And is it going to increase as time goes on because of our current lifestyle that we have in this country?
Well, actually, I didn't finish my story. Sorry. The radiologist who I was seeing came in for some problem, and I was just quickly looking at the imaging, trying to move through clinic, and I noticed he was interested in it. Then it hit me, oh, radiologist. Maybe I could show off right now.
Right.
So I added some time to his visit. I sent him back to the photography suite, and I had him get all of our imaging modalities, OCT, OCTA, and more. And then all my assistants, my nurses, my team were trying to pull me out of there to keep moving in clinic because we were both nerding out and just appreciating and helping him understand the beautiful imaging. So in terms of the epidemiology, there's so much to it. It's not an easy one type of linear disease. This disease is found all over the world. Globally, there's depending on the studies, there's over 100 million people with macular degeneration. And there might even be more because there's many people out there who are walking with it and have no idea. In the US, there is about 18 million or more people with at least early macular degeneration. And like I said before, generalizing it, about 10% of these people with early dry macular degeneration can convert at any time to wet macular degeneration, the advanced and severe and vision-threatening disease. There's a lot to it with genetics, with ethnicity, various diseases in the body that can lead to a higher risk. There is diet and food related nuances to this. For example, it's known and proven in the medical literature that those in the Mediterranean eating regularly a Mediterranean type of diet, rice, green leafy vegetables, fish, they have significantly lower rates of any type of macular degeneration and lower rates of converting to the advanced type. And there's so much just in terms of the epidemiology with macular degeneration. It's very important for the docs to know that and for patients to understand, the big picture.
And talk to me about inflammation being the core component of many chronic diseases and the role of inflammation in macular degeneration. We have about 2/3 of the population that's either obese or overweight. And having that big belly that's giving off these inflammatory mediators, how does that lead to inflammation and increase the risk of macular degeneration?
Well, just to show again how the retina and the macula is the window to the soul, to the body, and how so many things affect it. I wonder if a lot of the listeners knew that legitimate stress, just stress can cause a physical change in the macula. Stress can cause fluid to build up in the macula and cause vision loss. And stress reduction is a primary proven treatment for that, where the fluid goes away in cases. So inflammation, which virtually everybody at some point in life has inflammation in the body in different parts. So too in the macula, you can get inflammation that causes fluid to build up, regardless of macular degeneration status. But inflammation is an important component of macular degeneration and one of the risk factors for it, and also one of the targets for treating it. There's a whole discussion to have about the treatments for macular degeneration, but one of them early on, before we discovered a lot more, was steroids. Giving steroid injection into the eye actually had an effect, a positive effect for macular degeneration somewhat.
So you talked about genetics a little bit before, and there's a whole concept of epigenetics. So some diseases, the genetic component is extremely high, and the environmental component is extremely low, like say Huntington's disease. And other diseases, there's a bigger environmental component and a smaller genetic component. Where would you put macular degeneration?
Well, I've noticed that patients who are first uh, uh, see me or first get their diagnosis of macular degeneration, and it's a shock, and they're trying to understand it. One of the first things they learn and realize is that it has a strong genetic component. Something I try to impart on patients is that it's not like many other genetic diseases that are a little more easy to digest in terms of you have one specific genetic mutation and you have the disease or not. And I'm simplifying that. With macular degeneration, initially maybe they were looking for that holy grail, that mutation to find and then get the cure. And they found a genetic mutation. But then they found another and another and another. And there are so many mutations that affect macular degeneration. In fact, in the same eye, in the same body, you can have mutations that are harmful and are a strong risk factor for worsening macular degeneration. At the same time, you can have genetic mutations that are also protective. So it is very complex, and it's not an easy avenue to look into when trying to understand the disease and try to find therapies.
So let's talk a little bit about the signs and symptoms of macular degeneration. And this even gets confusing for doctors, eye doctors, whether optometrists or ophthalmologists. When do you call it macular degeneration? When we see a few drusen, or do we just, or if they don't their dark adaptation is poor before there's even drusen and there's this buildup in cholesterol in the RPE level of the retina. So when do we start calling it macular degeneration? Now you're a surgeon, so typically, and I'm an optometrist, so you will see patients usually when the wheels are falling off the bus. I'll see patients before the wheels are falling off the bus, where I'm just seeing early signs and symptoms of macular degeneration. So if you could kind of review that from the early, obviously, to when it gets terrible, where somebody loses vision from something we call dry or end-stage dry or geographic atrophy, or where there's new blood vessels that are leaking, and we have wet macular degeneration, which is very devastating. And we're going to talk about things that people could do to help prevent that. But from a retina specialist point of view, how would you answer that?
All right. Give me about 8 hours to answer. But I'll try to simplify it and make it a little easier to digest. Well, a precursor, and this is also something I impart at the onset of establishing a relationship with a patient, is it's very important to know that no one can feel their macula. No one can feel the inside of the eye, the retina. So it's not like many conditions in the body that you feel something and something's off, and you get it looked at, and when you figure it out, and you can also gauge how your disease is doing by, is it feeling good or not. With the eyes, everybody on earth at some point has eye pain or pressure or itching or scratching or strain. That's not retina. No one can feel the retina or the macula, and that's one of the reasons that it's imperative. Even if you don't need glasses or you don't need contacts or you have no problems, it's imperative for every human on earth to get their yearly eye checkup. Oh, I'm always told, but they always say you look good. What are you doing here? Doesn't matter. You need to get it checked up to hear that it's good, and you want to hear that every time. And God willing, it's a boring waste of your time, hour for life. However, very often, at some point it's there's a surprise found, and there's many diseases that are assessed and screened for that people don't realize. It's a lot more than just glasses at those checkups. And that's the first thing every patient says is, I've always had good eyes. And then all of a sudden, this crazy doc who sent me to you said that there's macular degeneration, but my eyes feel fine. Well, that's not how it works. You have to think differently for this disease. So macular degeneration, you can have it and not know because you can't feel it, and it could be very mild and not causing problems. That's why there's no impact on the vision. And that's when you want it found. That's when you want it diagnosed, because there's a lot of things to do to help it keep it mild and help prevent it getting worse. Dry macular degeneration is the main bucket, and that's what millions of people basically start with. There's early dry, there's intermediate, and it goes advanced depending on the risk and severity. Again, a lot of those you can have intermediate and still have perfect 20/20 vision, but then in a split second you can have wet macular or advanced dry, called GA, that instantly affect vision. Now, wet macular degeneration is when through the dry areas, an abnormal blood vessel grows into the macula and it behaves like a leaky fire hydrant and starts to leak blood and fluid. It can do so instantly, or it can be a slow process that you don't notice until it's beyond advanced and severe, where it wipes out your macula. And we want that caught a lot earlier. We want to prevent vision loss if that happens. To diagnose dry macular degeneration, you're not going to get a straightforward answer. There's little bumps under the macula, little calcification deposits that are called drusen. And again, you can have many of them and not know, and that still is dry macular degeneration. There's many different types of drusen, small, intermediate, large, soft, hard, cuticular. The list goes on, and they're always discovering new ones. And depending on the type, depending on how many, depending on the location, that helps officially diagnose dry macular degeneration. Sometimes people have just a couple, and you'll get arguments on if that's officially dry macular degeneration or if it's just having a few drusen. The way I look at it is, if you have some, it's better to be ahead of the game and to always be aware that you might develop further drusen where you'll definitely have macular degeneration. So might as well get defense on and the monitoring going, even if it's debatable if you have macular degeneration.
I would agree with that. Any time that I start seeing early drusen or early signs, any pigment changes in the back of the eye, but especially early drusen, even before pigment changes, we're going to start treating people with certain supplements, lutein, zeaxanthin, mesozeaxanthin, omega-3s. And we could talk about this, vitamin D3, K2, a multivitamin that has the B vitamins, because if we don't, at least we know certain things. There's a lot of research to show that these supplements can decrease the progression of macular degeneration, depending on the study, but they're all around 40%. So in our hands, trying to prevent them from getting to see you, because once they have to see you, then the wheels are falling off the bus and they could go blind. So we'll definitely like to treat them earlier. Let's talk about some of the risk factors. We always talk, everybody's always talks about, the biggest risk factor, which is smoking. People don't smoke as much as they do, but still about 10, 11% of the population smokes. And people that smoke, 90% of them, they've done studies to show that 90% don't even know that smoking could increase the risk of getting macular degeneration. So talk about some of the risk factors: smoking, obesity, high glycemic diet. What do you feel as a retina specialist are the biggest risk factors and some of the worst risk factors?
Yeah, really good question. Important for everybody on Earth to know. With any disease in the body, it's always important to know if you're at risk for that disease, or if you have that disease, what are the risks that you can mitigate? How can you help prevent that disease from getting worse? With macular degeneration, like I said, the foundational key component of it is genetics, and we have a lot to understand about that. What's which are the harmful ones, which are the protective ones, because you can get them all from both parents, and currently we can't really control that yet, but there's a lot on the horizon there. So what risk factors could we control? Patients always want to know, what can I do? Heck, the way I look at it is smoking is, depending on the study, you'll get the exact numbers, but smoking is a bigger risk factor because smoking, it's hard to quit, but smoking is such a strong risk factor that even if you quit, just by having a smoking history already, you're stuck with that elevated risk of getting macular degeneration. But it's never too late. There's studies that show when one eye gets severe macular degeneration, quitting smoking can lead to a totally better outcome and better prognosis for the other eye. Aside from smoking, there is diet, cholesterol, acidic foods, red meat, things that are that affect your cholesterol.
How about alcohol? How about alcohol as a risk factor?
Well, patients might like to hear this, but don't go begging to have macular degeneration. But alcohol, specifically wine, with some of the anti-inflammatory components found in the wine and the grapes, has a protective effect. That doesn't mean go pound bottles every day and you'll never go blind. But basically, depending on the study, having on average a glass of wine per day does seem to have a significantly protective effect. I did see some studies where overindulgence has a negative or harmful effect. So you got to really realize that too.
It could be like a U-shaped curve.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Let me ask you about anticoagulants like Eliquis, Xarelto, Pradaxa, Coumadin, and antiplatelets like aspirin and Brilinta. A lot of people take a baby aspirin every day. People who've had stents are using Brilinta. A lot of people who've had heart attacks are on one of the anticoagulants. Do you think those anticoagulants increase the risk of wet macular degeneration? Because there's different studies. Some say yes, some say no. And just from where you're sitting and seeing so many patients that have this type of disease, what do you think it falls from? Just your feeling of where you think it falls.
Yeah, it is a feeling because there are many. This question is a very common and important question that comes into play every day in my clinic, and there's many studies that some large, some small, some retrospective, some prospective, and some of them show that it has a negative effect and leads to higher risks of converting to wet macular degeneration, where one of the key components is bleeding. Or it could be where you're going to have the bleeding anyways, forget about the anticoagulant, but with the anticoagulant, it could be a more profound bleeding with more permanent vision loss, hypothetically. There's studies, really good studies, that also show no correlation. So do whatever you want with the anticoagulants. I think you see where I'm leading to is there's got to be, it's somewhere in the middle. In some cases, it clearly has a role in how things turned out in the macula, and in some cases, I can be shocked that how did this person have such a mild macular degeneration with all these antiplatelet anticoagulants the patient's on. I think one of the reasons to why it could be different in everybody maybe has to do with the genetics, depending on what your genetics or epigenetics are. Maybe that has a role in how anticoagulants are affected. But it's always good for the patient the retina doctor, the primary eye doctor, the optometrist, the cardiologist, or whoever's primary care doctor, to all be communicative in general, but to address this early on in the disease course, and to come to consensus and all be on the same page when giving the green light to continue the anticoagulant, or rarely saying maybe to hold off or to minimize it. I think the communication between the care team and the patient as the quarterback is the most important part of that.
I think everybody listening to this, it's really up to your doctor and your retina doctor to decide where you fall. I just bring this up, for educational purposes. I want to also, do you have any feeling? I mean, this comes up every so often about blue light, looking at these computers all day, digital devices. We're all staring at digital devices hours a day. Probably the average person, there's new studies, 4 to 10 hours a day. Do you think that these computers, these digital devices, are going to affect our macular in the long term?
I just want to reiterate the question, that the question is asking if they affect the macular degeneration. Not talking about if they affect eye strain or dry eyes or
Right.
visual function, but specifically for macular degeneration, absolutely not.
Okay, well, that's a good answer. I appreciate that answer. And because macular degeneration is related to inflammation, do you think that labs are helpful, such as C-reactive, high sensitivity C-reactive protein, or elevated homocysteine? There's been some studies that show that if you have elevated homocysteine, there's greater risk of cardiovascular disease. We know that runs with macular degeneration. And high sensitivity C-reactive protein, which shows inflammation in your body. Do you think it's worth it to get labs to see, well, even though they're non-specific, but you're inflamed and you want to do lifestyle changes to get rid of this inflammation to decrease your risk?
So yes, the inflammation is a key component. In medicine, we have various types of lab biomarkers that show, if someone has a state of inflammation, or how it's doing. Is it improving? Is it stable? And macular degeneration is definitely tied into that. However, it's not recommended to specifically do inflammatory lab panels for the macular degeneration, for diagnosing it or for following it. That is not recommended, because there's so much at play. You can do a CRP, an inflammatory marker on a patient, to see, oh, is it high? Maybe that means he has macular degeneration, but it could be high from any other disease in the body. So you don't want to, get confused and go in the wrong direction when diagnosing and monitoring the disease.
So about 80% of patients, when they're first diagnosed with macular degeneration, have already suffered irreversible vision loss. That's 80%. And approximately half, when they're first diagnosed, are 2,200 or worse. So we need to do better to help prevent this terrible disease, this blinding disease. Can you comment on that?
So yes, when advanced or when wet macular degeneration is diagnosed, on average, it's almost always, or it's usually one eye at a time, or one eye converts. And remember, the patient can't feel it happen, and it's kind of hard to understand this, but whoever's listening or watching, do this right now. You're looking with both eyes right now, and oh, everything's great. But imagine your left eye has disease in it that you can't see out of the middle, and your right eye's fine. Both eyes open, you're still going to be seeing normally. The right eye, in a way, compensates and fills in the gaps, and to the patient, you think everything's going well. And it could be at a highly recommended yearly eye exam with your Dr. Gelb. And when they cover up your eye when you get there to check your vision, that's when all of a sudden you realize, oh, what's going on? I can't see. That, or classic is you have the disease in one eye and you scratch your good eye, or you wake up and you rub your good eye, and that's when you all of a sudden are just using the eye with the disease. And that's often when a patient first notices, but that doesn't mean that's when it just started. It's a disease that can lurk, and as it does that until it's diagnosed, it gets more and more severe, affecting vision more and more and more. And while we do have therapies, the more time that disease is untreated, the more permanent damage there is that we can't fix. So it's imperative to catch the disease as early as possible. With the average patient catching it, just to simplify it, seeing the big E on the chart, if that's where you're starting at, it would be a win to ultimately just get a few lines of vision back, and that's not great. You want to get back to your 20/20 vision, or heck, you want to catch the disease and be able to prevent vision loss. That's ideal.
I mean, it's very sobering, to know that if about 50% of people, when they're first diagnosed, and their eye with the worst macular degeneration is 2200 or worse. I mean, that eye is pretty much, there's not a lot of times a lot that could be done at that point, because like you said, people walk around with two eyes and sometimes they don't even realize that the one eye is not seeing. So we've had treatment for wet macular degeneration for many years now, but now there is injectable treatment for dry macular degeneration. I mean, the results aren't great, where we're about 18 to 22% will decrease in progression. And there's two different medications out now, Syfovre and Izervay, if I'm saying them correctly. If you could make a comment, and do you have any experience with that? And if we could pick things up a little early, obviously, I think the supplements, the vitamins, do much better. We're between 40 and 90% decreased progression with lutein, zeaxanthin, mesozeaxanthin, omega-3s, D3K2, a B complex. But we're at the beginning stage where we're starting to get these new injectable medication that will give us maybe a little bit of help. If you could comment on that.
I'll try to paint the picture. So again, to rehash to the listeners, macular degeneration, for the most part, when it's at its onset, and hopefully if someone has it, that's how it stays put for life. But early, intermediate, dry macular degeneration, there's no impact on vision. The onus is to monitor in case it does advance and get worse, to be able to step in and treat the worsening or advanced macular degeneration as soon as it's caught. Advanced macular degeneration has two categories. So dry macular degeneration at the intermediate stage, if it advances, it can either turn drastically to this completely different disease, wet macular degeneration, where there's active leakage of blood and fluid that just continues to spread, and the more it does, the more permanent damage there is in the macula. So wet macular degeneration is one severe advanced form of macular degeneration, which I'll call AMD. The other advanced side of AMD is advanced dry macular degeneration. Dry is way better than wet, but wet typically happens instantly or quickly if someone converts to it. Dry, if someone stays dry macular degeneration for life, let's say, dry does progress and advance to what we call GA, or geographic atrophy. Their atrophy is thinning or loss of tissue, loss of function. And that's literally what's happening in the advanced dry macular degeneration. So those little bumps I mentioned, the drusen, that don't affect the actual macular, the nerve tissue of the macula, they start to cause atrophy, or literal loss of tissue, little serious gaps in the macula. So if your macula was like the film of a camera, if your eye was a camera and the macula is the film, GA starts, fortunately, much later in the disease process of dry, intermediate dry. And GA starts as a little pinpoint that you can't tell, where there's no function from that part of the film. As it progresses, that atrophy, that GA area, You can have multiple, or you can have it enlarging about, let's say on average, about a millimeter every year or so, where at some point it does start to become noticeable to the patient where you can't see. You have a big gap in that part of the vision, a big black area, and that gets bigger and bigger, and it can affect the center and it can spread. GA is just as devastating as wet macular. Fortunately, it's slower to begin, and it's slower as it evolves. GA had no therapies until recently. GA is a devastating disease because as a retina doctor likes to fix things, those are my saddest encounters, where when the patient starts becoming symptomatic, I can't do anything other than show sympathy and support. But GA finally has a new class of medications, anti-complement inhibitors, where we're literally injecting with a needle into the white part of the eye, into the fluid in the back of the eye, a medication, a little teardrop amount of fluid that has a positive impact on the GA. And it's sobering because it's not really fixing or stopping GA from getting worse. It's slowing down progression. It's the first medication ever. There's nothing else. And that's the way I paint it, is that's medicine, our field of medicine in general. It's when you get a revolutionary step in the right direction, a therapy. It's not it's not a gangbusters option, but it's a stepping stone, and it's definitely useful in many scenarios, but it's also useful as a bridge or a stepping stone for more effective ones. So the two GA drugs are Syfovre and Izervay. They're both the same class, and they have their small nuances, the differences, and they're an injection that we can offer to people with GA. It's an injection in the eye indefinitely every month or two, that slows down progression by about 20, 30 or so percent. So that's for GA. For wet macular, we've had injections for about 15, 20 years, where they're anti-VEGF is the family, and that's currently the only family. So, and we have several options, Avastin, Lucentis, Eylea, Vabysmo. There's more. While they're all in the same family, like Advil and Naproxen and Aleve, there are new generations for these anti-VEGF, and they are effective not just in slowing down progression, they actually halt progression of the wet macular, and they do have significant improvements of the fluid in the blood, but only to a certain extent. Their injections in the
Which
Yeah.
one do you have a favorite for wet? Is it Eylea? Is it Eylea, or is it the new one? Which one do you have a favorite?
So that's a tough question, because the nerdy, nitpicky OCD side of me, that answer is there are nuances and differences that, for the most part, don't really show themselves to be to make a difference in many scenarios. But there are subtypes of macular degeneration and different reasons where one drug might be better than the other. The way I look at it is that the first generation, Avastin, is great and miraculous. Before that, there was nothing. Retina offices were empty, and now they're bursting at the seams, and we want better therapies to help that. Then there was Eylea and Lucentis, and there's studies that show the differences, and basically the latest generation currently is Vabysmo and Eylea HD are very similar. Again, depending on the setting and the situation, one might be better than the other. But the way I look at it is, thank God we have them, and thank God there's improvements and advances happening every year now.
Yeah, because those Vabysmo commercials are on all the time, that they target both the VEGF and angiopoietin. So it has two pathways that it's
Vabysmo's and Eylea also are a steps ahead of the Avastin, in that they target more than just one and more VEGF. They're anti-VEGF and more. So they have a little more efficacy and more durability.
So where I'm sitting, I have we have patients that are at risk for converting from dry to wet. And in the old days, we would give them an AMSA grid. But we know the sensitivity of the AMSA grid is pretty poor on how that works. But now we have new technology, the 4C home technology. So can you talk about that and how, because I have a patient that is at risk for converting from dry to wet. I put them on 4C home, and because I want to know if they're going to convert, so I could send them to you immediately, so the patient doesn't lose vision. Talk to us about the benefits of 4C home versus the current standard of care, which I guess is AMSA grid, and how this could help our patients.
All right, so just to rehash, you just asked which medication is better. Even more paramount importance than which drug is better and having it and just having a treatment is catching it early. You can have the best drug, and if it's caught late, you're not going to do well. You can have the quote unquote worst or the first generation drug, and if it's caught early, generally they do very well. But the most important thing right now in all of macular degeneration is monitoring for wet macular degeneration development. Hopefully it never happens, but we put so much attention on the monitoring because no one can feel the macula. And if it converts, it's usually one eye, and the other eye, to the average person who doesn't know to check, the person will be walking around without realizing until it's too late. So catching early is huge. So what do? We have the eye doctors screening patients. It's often more than just once a year eye exam. When you have macular degeneration, dry macular degeneration, often the primary eye docs are seeing them twice a year, maybe even more if there's high risk. And sometimes the patients are annoyed by that. But that's because if it happens and the patient won't catch it, these visits will, and they'll save a lot of vision. At home, between the visits, it's important for the patient to monitor too. And it's important to know one eye at a time. And the gold standard is this grid that helps assess for any changes with your sharp central vision, which is where the macula comes in. If you see a change on that grid, sometimes it could be, something else, but if it is going to be wet macular degeneration, the grid usually would catch it, again, pretty late in its course. So we want something better than that, and no one wants to go see their eye doctor every single day. So a revolutionary advancement is the 4C home device by NotalVision, a great company. And it's this little cool device that you put on in your house, and there's a lot more to it than just a device that can screen for, with brilliant technology, for potential changes. If there are changes, it's more sensitive than the grid by far, and it would catch wet macular conversion way earlier than the grid would. Like you said, 20 over 200 or 800 is the average vision, and that's terrible. It's worse than legally blind when wet macular is caught. With the 4C home device, the vision is often about 20/40 or so when it's caught, and that's great vision. That's driving vision. My last few patients that were caught on the 4C home device actually had 20/20 vision when the wet macular was caught. How it works is you look into it without getting too techie, and it just takes a minute or two every day. The data goes to this centralized, cloud-based, mysterious void that's all safe and HIPAA compliant. And there's a monitoring team, the NotalVision monitoring team, and this is actually just as important, or if not more, than the actual device itself. The team assesses the results, and if there's any alarm or alert, the team notifies the patient, the team notifies the eye doctor and says, I don't care if your appointment's 4 months away, you got to go now to get checked. There's a high risk that this machine caught a conversion. And it often does that at a very early stage, and that's what we want. the other thing I tell patients is they have great customer service. If you're not technologically adept, if you don't know how to use computers or phones well, their customer service are very responsive, and very helpful with onboarding you, addressing any questions or issues. For doctors prescribing it, a lot of times we don't have a lot of time, so it's hard to incorporate something new. But I just tell the patient about it, basically, and the next thing you know, the patient's using it, and I didn't have to, spend any extra time with helping them get set up. The company does that, and insurance often covers it.
So I know in my office, if I see somebody who fits the category who I think has a potential to progress from dry to wet, we have a form we fill out, we fax it into Notel, and then somebody will call the patient from Notel and get them set up and teach them how to use it. Is that pretty much the way it's done in your office, or am I leaving something out?
Yeah, so that's the nutshell. It's simple. It's the patient should look at it as, patients with macular degeneration are very, very nervous. Doc, is seeing you once a year or twice a year enough? Ideally, you would be seen every day, but this helps keep the patient protected and safe, and has so many extra layers of monitoring thanks to this nodal vision monitoring team and the device. It really kind of creates, with the primary eye doctor, if there's a retina doctor involved, it creates a really good team that takes care of everything for the patient. And it's just reassuring, honestly.
A patient comes to mind that I had put this on. A patient I've been seeing for a number of years, and I had them on all the supplements that I do. We check the macular pigment in my office. Typically, I don't think too many retina people do that because by the time they see you guys, the wheels are off the bus at that point. So I'm looking at prevention, and they went off this prescribed supplement that I use. I usually use MacuHealth. That's the one I use. But they bought one of the ones from Costco, and they progressed. I don't know if that's the reason why, but it wasn't working as well. They progressed, and then I send them to the retina person, and and it picked it up around 2025, 2030, and otherwise the patient, because I might have had that patient coming back in 6 months rather than 3 months, and their vision could have gone from 2020 when they started using this instrument to 2400 or 2200 studies show. So that was one of the cases, and I'm sure you have cases like that. Do you have any stories that you could share with patients that you've had that you were able to intervene earlier, so you're not dealing with a catastrophe, you're not dealing with a 2400 eye, you're dealing with a 2040 eye or 2030 eye, and of course the results are going to be much better when you do that.
Yeah, I definitely do. But I'll even give you a general story. Years ago, before the pandemic, I started working as a retina doctor, and I was busy from the get-go, and I didn't have any experience with the 4C home device. I would just quickly give the patient a sheet of the grid and say, yeah, use this, and rush off to the next emergency. I was honestly kind of very skeptical. I thought the 4C home device was voodoo. I didn't have time to look into it. I didn't have time to talk about it at the patient encounters. And just in hindsight, honestly, that's kind of doing the patient a disservice. We should all, as providers, be, up to date with everything, with what's out, whether you're a strong believer or not, if it's safe, if it's proven, if there's medical studies that prove its efficacy. You have to the patient, tell them all their options. I started looking into it and using it as the pandemic started. Patients weren't coming to the eye doctors for the regular eye exams, and even to the retina doc when they had high risk dry macular degeneration. Often they couldn't come to the retina clinic, and many of them didn't come for 9, 10, even 12 months. And it was a daily thing. I'd get a million phone calls patients crying, patients concerned and nervous. What if this happens? What, I can't tell if this, everybody was distressed because they weren't having the oversight. They didn't have the doctor care team helping them. So that's when I started saying, okay, maybe, you know, psychologically, maybe giving them this device at their house, it can help, you know, assuage any of their concerns, or at least somewhat. And I was, you know, humbly speaking, I was spot on. The patients felt so much more relieved and a lot more confident that things will be okay. There was a lot of anxiety back then, if everybody recalls. And I found that striking, that that little device that I was just delving into really helped all minimize the phone calls. It helped patients, you know, get through that tough time in our life. And I'm happy that I learned about it and got accustomed to it, and I'm a big believer. I think patients love it. Patients that come to me from other doctors who haven't prescribed it, when I mention it, you know, honestly, it seems cutting edge and it looks good. And there's a lot more advancements coming also in that department for the 4C home.
So
that'll
talking
be
about advancements, we talked about OCT before, which basically
read my mind.
which peels the layers of the retina by looking at it with an image using light. So there's going to be a home OCT, which is, I believe, can be available right now. How could that help us with patients along with the four-seam home? And where do you see the difference and where somebody would use four-seam home or where they would use home OCT technology?
So, you know, patients that see the eye doctor, most eye exams at some point, patients will remember that green star camera that took a picture of their macula. That's the OCT. It gets a grid of your macula and looks at the layers. Very easy test, no puff of air or anything scary like that. And retina patients, virtually every retina patient that walks in the door with any disease gets an OCT at every visit. And people can quickly tell that that's our workhorse. We rely heavily on that miraculous technology. The OCT shows us all the layers in depth of the macula. It's not just looking for functional changes like the grid or the 4C home, which is higher power function. The OCT is the gold standard. When we follow patients who have risky dry AMD, and based on our estimated guesses, they're low risk, okay, maybe see them in a year or twice a year. If they're high risk, just to hedge our bets, we see them every 3 months. Patients that have wet AMD that are getting injections and things are stable, we're always concerned about a major bleed, a major step in the wrong direction that's catastrophic. So injection patients, we watch very carefully, come back in 4 weeks. Oh, it looks good, come back in 5 weeks. And the patients say, just a week more, why not another month? Because we're always hedging our bets. We're afraid that, you know, things can go backwards if we give you too much time off. Well, it would be a lot easier to monitor dry and wet macular degeneration and with living proof to guide our decisions. If the patient does that scan every day, like I said, they're not going to come to our clinic, but can you imagine that technology in the patient's house? That I, as an eye doctor for a patient, I can look at that scan that they just took at home and not have to guess or estimate if there's changes. I can literally see. Now, colleagues will say, "Oh, this is going to be bad for business. There'll be less volume, less patients. Heck, who cares? We always want to do what's best for the patient." And honestly, we love the baby boomers, but there's so many patients just walking in our doors. I'm putting out bunk beds in the waiting room. So the home OCT will be a revolutionary game changer in how we do a lot, but how we follow patients with dry and wet AMD. There'll be a lot more comfort with patients being monitored at home.
I mean, this is amazing. Two technologies that could really save vision. I mean, we're going to pick up people that progress, that are on treatment, that are progressing quicker, get them in for treatment to the retina specialist like yourself, or people that are still dry with four-seam home and we'll be able to pick them up real quick to be able to be treated so patients don't go blind and they don't wind up with 2200, like the study where about 50% of the people are 2200 or 2400 vision when they're first diagnosed, and that's the majority of the people. So this is great technology, you know, that's starting out, that could really help our patients. And I'm so excited that you were able to come here and explain it. Dr. Sidney Schechet, if I'm saying your name finally right.
Yeah, sounds good to me.
You know, and so if people want to find out more about you, I know you have a YouTube channel. How can they do that? Or they want to see you as a patient in Maryland? How can they do that?
Happy to see anybody. I don't treat prostates or fix twisted ankles though, but I work in Baltimore, Maryland.
How about hair loss? Can you do anything with that?
I don't know. I like your style. I don't want you to change it. I work at the Elman Retina Group in Baltimore. We have several locations where we are involved in a lot of clinical trials. Very exciting, one including the home OCT. And you can check us out on our website. We have a lot of cool and helpful educational materials. I don't know if I should share it, but my YouTube channel has a lot of videos and surgical videos on the retina, and it's not the boring nerdy doctor type videos with the monotone voice. I like to make it entertaining for docs and for people who don't even know what a retina is. So get some popcorn when you watch it.
What's the YouTube channel?
I think it's Sid Schechet.
Check it on YouTube. Well, everybody, please check that out. I want to thank Dr. Sid for joining me today and sharing some incredible new technology. Thank you, Dr. Sid.
Yeah. All right. Have a great day. Have a great night. Thanks for having me.
Thank you, everybody. Thank you.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.